Okay, everybody. Dr. Bishara is now online, and I want to introduce him to you. It's Dr. Bishara from Dallas, Texas.
Hi, good morning, everyone. Good morning from Dallas, Texas. Thank you for joining us for our first webinar here with Restoration Robotics. I'm going to be centering the robot and be getting underway shortly here. So throughout this morning, I'm going to be sort of trying to explain, I think, what we're doing. And most of you probably have had at least some form of introduction to the case. How many people have not seen an ARTAS case before? Is there anyone that has not? Okay, great. Well, welcome. I think that you're going to be very pleasantly surprised about the way things work today.
Okay, so I'm going to switch to a view that you haven't seen yet. Well, I've brought it up, but it's actually now live because the patient's seated in the chair. And this is the software user interface view, and I think this will be one of the more powerful views, and Dr. Bishara can speak to this as we're going along. And right now the system is acquiring the skin tension device, which is really acts as a datum. So all the graphics that you'll see in the that are drawn over the screen are actually made possible by those little markers you see on the side of the tensioner. They almost look like dominoes. So it's getting started right now. It's beginning to harvest.
This is great. We are beginning to harvest. I'm going to be changing a few things about my settings, just the diameters of the different harvested temps. And we have a lot of different metrics. We'll try to keep most of our discussions basics, but basically what I just did is I increased the size, the harvest grid. Each time you see a turquoise circle, that circle represents where a previous FUE harvested temp has taken place. The green is the next harvest attempt that's about to be executed, and the purple is the one just in front of it. So you have sort of a real-time assessment of what's going on, as well as what's been previously attempted. Now you can modify the width or diameter, of that circle, and make this dissection process or the harvesting process more aggressive or less aggressive. So what we try to do is figure out a parameter based on his predicted density, and we see up here that 80 follicular units at the top of your screen, right in the middle. You'll see right at the top you have a digital readout of the density of the grafts, and this tells you basically how many grafts that you should be able to take without getting sort of into a moth-eaten appearance in the back. So it kind of gives us guidelines on how aggressive we can be. Obviously, we don't want to take. Sure, go ahead. That's correct. There are two things that are happening here. If you notice where my mouse is hovering over this dissection, this is the dissection that has just occurred, and it's showing you the inner sharp needle. It has two lines on it. The lines are associated with how deep that needle, that sharp device, is going in and scoring the skin. And so if we know that this is what we refer to as sort of the skin line, we know that that's perfectly calibrated to break the surface of the epithelium, but not have that sharp needle go in too far that would increase, of course, our transection rate. Then as soon as that is scores the epithelium and the first layers of the skin, it's followed by a dull device that goes on the exterior that cores down. It's a rotary 360-degree dull device, very similar to the SAVE system developed by Jim Harris. It's just a dull punch, and it sort of goes down around the outside, and that prevents the follicle from being damaged, or at least minimizes the chances of it getting any type of instrumentation damage. And then so you're seeing a representation of the last graft that has been dissected, and it's been done perfectly here. You can look and notice how the hair shaft sits in this gentleman. This is a 3-hair follicular unit. It sits directly in the middle. This is a 1-hair follicular unit. This is a 3 or 4. This is a 2-hair follicular unit. The hairs are repeatedly right in the middle of your skin plug. And so that's the real advantage that you see by using the ARTAS machine, that even when we look at harvest attempt number 1,000, or when we get to 1,500 or even 2,000, this does not change. This stays the same. And that's not true for a lot of human models. As the acuity of the eye gets tired, the ability to accommodate and your precision goes down. Correct. And now I'll introduce you guys a little bit more to the interface here. You can see the elapsed time up here for dissection. That way, when we're done actually today, we don't have to look at all of these and be aware of them in real time. It's being recorded, and a PDF file of approximately 4 pages of different metrics can be populated at the conclusion of the case that tells you about the many different things, like the average dissection depth, all kinds of things that you can follow, and if you want to study them in your practice, you have the ability to populate those reports routinely. Over here we have a number. We have the number 1 listed. That's the grid number, the number of grids that we've actually reacquired on, and this is the group number that we're on. Sure. I'm sorry? Yes, correct. And so we were just talking about that when we started. The turquoise color denotes clearly denotes that has been a previously harvested attempt, and it tells the robotic arm not to go back into that area. And so the green circles, or which should be showing up as green, there's really only one green circle, one large green circle. That's telling you where the robot plans to have its next dissection, and the purple is the purple circle that occasionally will flash in front of you, shows you where we're going next. So it's kind of a prelude to what's going to happen in sequence. Now, when you look at all the green dots, we refer to the green dots that are over the entire field here, and there's hundreds of them. Those represent grafts. Those represent hairs that are multifollicular units that are sticking out. And so if you have the hair too long, and the hair in this procedure needs to be about 1 to 1.2 millimeters in length. If it's much longer, then you get overlap of the hair shafts. Now you can see, if you look across the board here, you'll see that the hair shafts don't touch each other for the most part. And occasionally, if they do, where we've left some hairs erroneously, left them a little long, like this hair here, you can see this hair is registering. I'm pausing it so you can look at this. But if you leave it too long, this hair and this hair registers as one hair, and that number will drive down your density that's being measured, and it'll drive down your ability to efficiently harvest and yield different grafts. So you want to make sure that you minimize this type of phenomenon. You don't see it very often, but at least it allows you to be more aggressive in that area. God bless you. That's correct. That's correct. So you have dots. You have multiple dots in each circle, right? You have green dots, and those green dots may be as many as 9 or 10. So it's safe to assume that even at a very aggressive harvest rate, we're still only taking 1 in 9, or maybe 1 in 10 hair follicular units in the donor area, and that's despite having, extremely aggressive parameters. We can still come back in that area and not have to worry about being over harvesting. We can come back in this area even 2-3 times if we need to. Now I can direct the robot to go down and sort of take certain grafts. I can also tell it, let's not dissect, by putting a yellow dot. I can right click on my mouse and tell it, don't dissect in that area. So this is kind of like what my good friend Dr. Mohan, who developed this system, what he described to as having a car and driving a car that's in auto sort of a cruise control, but yet you can still tap the brakes. You can still tell the car, I'm going to turn right, I'm going to turn left, but nevertheless, you can put it in some degree of an automation mode, which is happening before your eyes right now. The computer is deciding where it wants to go. The counter of how many harvest attempts is right here. So 120 harvest attempts thus far. It's been about 8 minutes. We can right click on that elapsed time. It'll tell you what my local time is here. It's 9:23 in Central Standard Time, but it also tells you what's our average harvest speed. Now we're up to almost 850 grafts per hour right now, so we're doing phenomenally fast. Our average harvest speed is probably around 1100. We're usually running even substantially faster than this, but there are different things that are patient specific that can help improve this, and other things that are that can actually slow this down for safety reasons. So in some cases where we might have a significant amount of dermatofibrosis, or where it's a very difficult, where you're requiring a lot of force to get through the skin, then that will slow down our ability to dissect. Now, at the conclusion of the dissections here, you should be able to see that these grafts are sort of sitting in their holes, but they're just ever so slightly out of the hole. And I'll talk to you a little bit about this in just a second. Now we've finished the grid. Okay, I've got my assistant who is going through and extracting different devices. I'm going to go ahead and I'm going to safe position the robot. And I'm going to go ahead and perform a saline flush so that the system gets flushed through. And so any fragments, any discard, any capping that may have occurred that's stuck in the suction line will get flushed into a trap. Sure. Right. Well, I'm doing it. I'm in my office that's behind a one-way mirror in another room with a monitor, with an audio monitor, and three different video cameras that are set up so where I can see the patient in real time, and then, or actually 2 different cameras that I can see the patient in real time. But then with our webinar, we have a couple extra cameras that are sitting around. So I have one that's clear view of the procedure going on. And then I have one, I have sort of a direct visualization through the window, and I'm using this to be able to multitask. I can answer emails while I'm doing this on an iMac that's right next to me. I can answer phone calls without disturbing the privacy of the patient, or without the patient having the perspective or the thoughts that I'm maybe not paying attention to him. So I can still maintain a high volume practice and not have to continuously excuse myself throughout the day. Does that make sense? A lot of surgeons are in and out of the room. That adds to infection control issues that are oftentimes overlooked. It also adds to invasion of privacy to some extent, and so in our practice we found that it just works out best to be able to limit the amount of people that are in and out of that room throughout the day. Yeah, so that's very, very, very astute point here to sort of think about. You can do one of a couple things when you're doing that. You can either, if you know that you're going to come back, if you have somebody who's particularly follicularly challenged, or you have a high thoughts that someone is going to be back to have an additional procedure, you can either avoid going through those areas, or you can decide to decrease your parameters through those areas the first time, knowingly that you're going to go back through that area. So there's a couple ways to approach it. It just depends on how many grafts you need and how big are your cases, and so if you're going to go back in that area, my thoughts are be a little bit more conservative and spread out your donor area a little further out. I caught the back end of a question regarding what are the advantages to the robot versus a manual or motorized FUE. Was that the question? I'm sorry. Okay. Well, I mean, it depends on which human model that you compare it to. You know, if your practice is a practice that is well equipped with different FUE devices, and you're able to routinely extract or dissect 1,100 grafts per hour, and you have multiple patients that are presenting for your procedures, and you can handle them all at one time, that's great. But in my practice, the way that we've used it now, I'm I'm still as fast, or maybe in some instances probably faster, with using my hands with the robot. But I can tell you that after about on Thursday or Friday, before, when I was doing motorized FUE, I can tell you it's a very difficult beast, because you're a lot more fatigued by the end of the week. And so I know that I'm not as precise as I am a first thing Monday morning. I can tell you I had a traveler who came in on Tuesday, for example, which came from Mississippi, about a drive almost 10 hours away from our home base, who came for a body hair transplant. And as you guys know, the robot is not approved for body hair transplant yet. But this was a day where I was doing 800 grafts of body hair transplantation, and I was exhausted. I had sort of almost a tension headache from exhaustion, and then brought him back the next day and did another 800 grafts body hair. So there's a fatigue factor, first of all, for wear and tear on ourselves, and number two. If you're doing 1,500 grafts FUE or 2,000, like we'll routinely do, the difference in time in using a human model versus a robot is most likely not going to allow you to do an additional case during that day. It may allow you to finish up 30 to 45 minutes earlier in some instances, but in our practice, it's pretty much about the same. So, using myself being, I think, a very skilled FUE surgeon with my hands, I still don't think it speeds much up out of the day. It doesn't allow me to do more if I do my hands. I can't do 2 or 3 FUE cases in one day. I might just, I may finish 30 minutes or 40 minutes before if I'm using my hands. It's just, but I get tired by Thursday. So that's probably the most... operator fatigue is probably my biggest deal. Number two, and what most people, for patient safety and patient delivery of a good product, it's going to be talking about repeatedly being able to produce those precise grafts, and that has to do. It's not mutually exclusive from operator fatigue. They're all sort of one and the same. So I think really precision and repeated precision is going to be your best advantage. Now, number two is patients. Sometimes they want to know. Sometimes they think they've been bamboozled. They think that they didn't get enough grafts, or maybe they need something. They need an op report to tell them exactly how many grafts they did. Well, as you know, with a NeoGraft or with an alpha graft or with any other model, it doesn't really. It's not necessarily going to keep track and produce a report. So if you need to give someone a report of how many harvest attempts they had, you just push print, and you can give them a 4-page report. You can share them the metrics that you're measuring, that the robot measuring. It takes you out of the picture, and it gives them kind of a sense of ease, and calms their mind sometimes. We all have those patients.
Couple of...
Right. Yeah, so sure. Yeah, so that study, as far as FUE grafts being outside the body, has been done. It has been reproduced. It's been done in a murine model, in the mouse model. Jerry Cooley speaks to this quite frequently. But if you're using high potassium solutions, and we do not use normal saline anymore. That's something of the past. We haven't used normal saline, I think, in over 2.5 years. We use hypothermosol, which is a high potassium solution. It will drive down the metabolic demand of the cell. It reduces oxidative stress. So in the murine model, you're seeing high 90s, high 90% viability at 5 days in the refrigerator, kept in the refrigerator for 5 days at 6 degrees Celsius. So, you're really at a point where it really doesn't matter. I know Parsi from Southern California had presented something about survivability this past October down in the Bahamas. He spoke about, how long grafts can survive. And traditionally we've been taught 5 hours, and there's really just, there's good science to suggest when you're using holding solutions such as hypothermosol, you're going to be able to go well beyond that time frame. Now, the second question that you asked was, and I forgot, it has escaped me. Right. Okay. Right. So basically, I'm not involved in the R&D side of the different phases of the rollout of the robot. I do my own clinical trials. For example, we're, I think, the only practice in the world that has a grant to study African American or wiry hair using a robotic device. So there are certain things that we do. However, I'm not involved in the R&D part of phase 2 or phase 3, which is recipient site making and an implantation. I'll defer to the restoration robotics department for that.
Hi, Rakesh. This is Mike Oren with Restoration Robotics. We're working on it. It's certainly something we're looking at, but we currently don't have a timeline for that.
Yeah, I'll speak to Mike's discussion too. At the first Artist Summit, we did have a prototype that has that's taking pictures, that's creating a 3-dimensional model that allows us to look at the number of hairs that someone could potentially look at. It's certainly a beta version where it sort of implants. It gives you a computer recognized model, and a very unrealistic looking model, but it acts to kind of provide patients with a operative plan or an idea of how many grafts they would potentially need to get the desired coverage. So, and that's you said implantation relies on direction. And how do we decide on the direction of the recipient site making to therefore complement the growth so that it looks very, very similar? So that's probably something for the R&D guys who are developing that software. But we see an array of different types of techniques in the literature. Correct? I mean, we see sometimes people are making recipient sites in the form of perpendicular angles that are kind of loosely referred to as cross-hatching. And that technique is done to sort of add density. So that's something that kind of doesn't go in keeping with creating recipient sites, in line with the existing hairs. And so I think that it'll probably have to do with some degree of representation of the angles and the direction of the existing hair follicles, and then deciding, do you want to employ a cross-hatching technique, or do you want to make a recipient site that goes in parallel with the existing hair follicles? That should be an easy one to figure out. That should be basically a mouse click after the algorithm's built.
So you've got a couple of questions, Dr. Bishara, from some folks in the chat. I was going to pass on for you. Alan has asked, how much tumescence do you inject in a single grid?
Right. Well, so now that number has changed. Okay, the amount of tumescence that we will inject depends on the laxity of the skin in the donor area. Depends. It's a patient-specific type of phenomenon. As much as we need to, really. That number sometimes can vary between 1 cc of normal saline And if we have a lot of bleeding, or if we have a lot of oozing in somebody who's very vascular, or maybe on aspirin, or maybe even somebody who has a lot of curry in the diet, those can be antiplatelet types of functions. Then we'll oftentimes use a little bit of epinephrine. I do use epinephrine in FUE cases. Some people, such as Dr. Bernstein, will not. He tries to avoid using epinephrine. I haven't seen it be a major factor on our growth. So excuse me, 1 to about 3 cc's of tumescent per grid is sufficient.
All right. And another question came in is from Alan as well. What is your secret for moving the grid to a new place so fast?
Right. So we've been asked this by multiple people. You get to know the nuances of a procedure when you push the envelope on the number of grafts, and so on the number of grafts that you're trying to perform in one setting. So you know the device's limitations, and you know how to explore the economy of motion during this procedure. We've done that. Excuse me. Our secret is that instead of starting at the top near the occiput, the top of the universal donor area, we start a little lower, and we march cephalad, or towards the vertex. And so that is probably in the minority. I think the teaching, when people are using the robot, when they do your training, they teach you to start at the top and sort of march downward. Well, we've decided that because of the angle of the approach and the profile of the actual tensioner, if you start at the nape of the neck and you march upwards, you will be able to get on the order of about 20 to 30 more grafts without having to move the grid by getting an additional line. So you can see that you're able to get more of the grafts up in this region. And so our overlap at the bottom of each tensioner will be about 3 to 4 rows of harvested grafts, because we know we can't get to those grafts anyway. So we have good overlap. Now, the second thing that we'll do is that we'll leave 2 of the elastic bands strapped, and we'll raise the tensioner sometimes, and we'll advance it forward without having to completely disconnect the entire device. So we'll only do 2 of them, and then sort of march up by leaving 2 intact. Does that make sense? Hopefully that makes sense. If it doesn't, I'll try to say it in a different way. Now, if we're really, really trying to make this thing work really fast, we won't always use a safety flush in between each grid. If we have a dry field like we do today, the field is very dry, we don't have a lot of oozing, then our vacuum system probably is not tainted with a lot of dried heme. Then we can always force drag away, reposition the tensioner, and then reacquire by force dragging right in. Now that will modify some of the metrics on the case, but it allows you to get the case done and shave off anywhere from about probably about 45 seconds to a minute. Yes, I hate operating on patients who are diabetics. HIV positive, however, we don't really modify our technique. We try to treat everyone as the same. We try to treat everyone as if they are a biohazard. Certainly a biohazard for exposure reasons. For diabetics and patients who are on end-stage renal disease, those patients can have sometimes poor growth that are based on just in general glycosylated growth factors, or they can be a deficiency in protein that you may not always be aware of. This became sort of evident to me when we had an episode of poor growth about a year ago, a little over a year ago, probably 18 months ago when we started a case. And about 6 months in the postoperative period, I performed an abdominoplasty on the same patient. Well, for no good apparent reason, he dehisced, and he was an end-stage renal patient, wanted some hair, wanted to look a little bit better. So we performed his operation in an operating room in the hospital setting, and he dehisced on day 4 or day 5. Well, when we looked at his prealbumin, it was about 7.5, or almost 8. So, I mean, I think you have to be mindful of these patients who come in that are not ASA 1 classifications that are going to be potentially, compromising your growth. So I think it does affect how we approach them. And I think we try to manage their expectations by lowering them slightly. Sure, keep them coming. That's fine. Sure. Yes. Yes, we are. Yes, we are. We use it. We use it now unanimously on all patients. Okay, so we haven't begun to use ACell, but we are using PRP on all patients. Now, a few things about PRP. We will not be able to, for a while, to figure out exactly, we won't be able to quantify the benefit from PRP in hair restoration. I know Dr. Lamb, who's here from Dallas, he has been doing it for, approximately about 2 years, and Dr. Cooley maybe about 8 years now. And so their experiences have been a little bit more vast than ours on it. We were doing on a case-by-case basis as frequently ago as probably about a year and a half. And then we went to realize that on cases that get poor growth that happen maybe as frequently as 1 in 50 or 1 in 100, those patients might have had a difference. They may have had something that was a noticeable change, but we don't know which one that's going to be. And so I think that in itself is probably worth being able to really investigate by employing a PRP across the board.
We had a question from James. He says he didn't see you change any of the settings, PD, CD, angle, or RPM at the beginning of the case. He's asking, did you set it up beforehand, or is it set to defaults? How did the number come up for this particular patient?
Right. Well, so if you would be observing this case a year ago, it would have been quite different. You would have seen me going through a series of parameters that was causing us to sort of look differently at certain things. Hang on 1 second here. Rebecca, can you force drag to the upper left-hand corner, reacquire, and let's start over on this one. Okay, so if you were watching me about a year ago, we were unanimously having to go through and set those devices, but there are algorithms that in the first 3 or even 4 harvest attempts, the robot will actually be able to adjust for that based on some feedback that it gets from these lines. Does that make sense? Hopefully so. That was written in, so we won't get a verbal response from that.
And another question from Alan. He says, it looks like you were blocking out the lower portion of the grid, but pushing the edge on the upper part of the grid. Is there a reason behind that?
Yes, there is. There's actually a profile of the actual tensioner. If you see down, we can't get, as the angle of the grafts dissect. Okay, they do so, or the angles are sort of are pointed towards the lower end of the actual tensioner. Okay, when we approach this area, we're limited by the profile of this device, and so we have to respect the profile so that this needle device doesn't bounce off of it routinely. Now, there's a built-in no-fly zone indicated by the yellow line, so nothing below this can be really attacked. Because if you think about that, the angle would transect that graft, and so we don't want to transect them, so we're going to cheat up a little bit away and sort of come in that way. So our overlap will oftentimes be 3 or 2 rows, depending on the angle. This is the angle up here in the upper right-hand corner. And so if that angle drops below 20, below 30, then we'll typically leave 3 rows of harvested angles. If it's above 30, then we'll leave 2, because we know that we can approach that at a higher angle or more acute angle. Hopefully that makes sense. It depends. It depends. How old is the patient? What is the level of anxiety? Is there a problem with the lumbar spine of that patient? Does the patient have an overactive bladder? I had one the other day that was a bodybuilder that had to get up every 45 minutes and eat a protein bar. And so that will limit the amount of time that you can spend, in the robot for that day. And so, yeah, if you can predict that you're going to spend extra time doing certain things or taking extra breaks, then you're going to limit that graft case. Now, we do graft sizes. We have done graft cases that are controversial. They go beyond the traditional no-fly zone for a lot of patients, and some providers are very uncomfortable doing that. We're not. We're sort of we are able to be sort of transparent with patients. If we do encroach on that no-fly zone, we tell them, this is an option you have. You might be able to wear these grafts on the front of your head or in an area where you think that they're more valuable for even 5 or 10 years, but they may not be a permanent solution for you. And if you go on to lose hair in other places that encroach on that area, you may even have some hypopigmentation or a small dot scar. So as long as you're up front and you're honest with patients, I think you can do it if you have a reasonable patient. If you have one that's really fraught with false hope and all, then of course you're going to have to play God and tell them that's not a good idea. But if they're reasonable, they understand the rules, then you can push the envelope up to 3,000 grafts for them. I think that's fine. Sure. Sure. The challenges are going to be they're going to be related to the number of grafts that you can do in one setting. They're also going to be getting used to know where there's a few sweet spots on the tensioner, and that just comes with time. There's a learning curve with everything, and so the learning curve for us, I think, was just being able to. The sooner that you get the bigger cases, the 2,000, the 3,000, even 4,007 we've done. When you do these bigger cases, you'll figure out the limitations and the learning curve. You'll be propagated through your learning curve much faster. If you continue to do 400 or 500 graft cases, you're doing little hairline things or maybe some crown work, then you're going to sort of be limited in your learning curve, how quickly you can get through it. So we do have a generator, backup generator that will kick in, and there are certain outlets throughout our throughout our operating room that are plugged into those. They're usually signified by a red outlet in the United States. We have to do that as part of safety backups, and so yes, fortunately, if the power does go out, we do have an emergency backup system in place, and emergency lights do go on.
Yes, this is Mike. So inside the robotic, inside the cart, there's a uninterruptible power supply. It's a rather large one, and it engages if if I were to walk in the room right now and unplug the system, basically the webinar would come to an end, but the system would continue doing what it's doing. And it just warn the operator, hey, the power's been lost. You should probably pause the system and shut it down in the meantime. But it wouldn't interrupt what the system is actually doing. All the pumps and the robotic arm and the software would remain powered up during that time. And you've got about 10 to 15 minutes of time once that happens.
So I'm just going to tell you a little bit about a few things that I want you guys to kind of look at. Now, the most important thing, coined by Dr. Jim Harris, he led at the first ARTAS symposium that he talked about, is something called optimal graft elevation. So when we look across the field of dissection, we're looking for, are these grafts elevated in their holes? Have they been sort of, are they coming up? Do they need more dissection? You see some empty holes here because there's some technicians that are running behind me behind the actual robotic arm that are actually extracting as we go, so that they can start to count and do quality control measures. But you can see how these grafts, if you look up to the upper right hand corner where my mouse is, you'll see that that graft is sitting in the hole, but it's slightly elevated. That is being elevated at the conclusion of that second dissection. It's actually being lifted up by a small pneumatic pump that allows it to sort of sit inside that hole, but be, just above the surface of the skin. And that tells us that it's been freed up by its intradermal or even subcutaneous fat attachments. And so it can be easily removed or extracted by using a jeweler's forceps. So that's the single most important thing in robotic FUE is optimal graft elevation, OGE. Those are great questions. All great questions, not only for robotic hair transplant, but for the field of FUE in general. Yeah. So extraction or dissection? There's two different questions here. Dissection. Okay. So I'll refer you to this. Average harvest speed. So far, our harvest speed, which is the speed of the needle going from graft site to graft site, and this will modify every so many harvest attempts, but we're looking at about an 820, just over 800 grafts or harvest attempts per hour. When you look at this and you look at the time of elapsed speed, we're at 43 minutes and we've performed 460 harvest attempts thus far. So, when I look across the board, aside from this case, and I kind of take an average of different cases, it's probably common. If I know I'm going to do 1,000 or 1,200 harvest attempts, then it's going to be around 2 hours and 15 minutes in the robot in general. Now, I can speed that up. I can make that be substantially faster. I can make it be, probably around an hour and 50 minutes. But we really have to do some things as far as, modifying our techniques and not necessarily flushing between each grid, etc. So we can push the robot and make it go faster by eliminating some of the steps between each grid. Oh no, I would extract, and what we do is all of the grafts that are taken in the first hour of the case, okay, they are put away in a refrigerator under hypothermosol, and they're measured, their temperatures are measured by a laser thermometer at 6 degrees Celsius. We have about 8 lasers here. We do a bunch of different cosmetic procedures, and one of these devices that comes with heating the surface of the skin is a laser thermometer. You basically point it and shoot it, and you can tell how cold the solution is. So we do that routinely throughout the case, and we record those temperature readings just to make sure that we have a proof that of what we're doing. And what we'll do is take all the grafts that were from this first hour. Okay, so here in about 15 minutes, we're going to take all those grafts, put them in one medicine cup, and we're going to put them in the refrigerator. And those will be the first grafts when we start to dissect or when we start to implant. Those will be the first that go into the body. Does that make sense? Yep. So that way, I think that speaks to your concern about, are we damaging these follicles by putting them under oxidative stress in an anaerobic environment? And there's no question that you are, but can you minimize that? And that's the benefit of using hypothermosol. Hypothermosol from our current contract cost me about $160 for 100 ml. So if you know, a Coke can or a 12-ounce can of Coke is about 355 ml. So it's about 1/4 of a typical soda pop can in the United States. So it's a very, very small amount. Now, from my distributor, I know that normal saline costs me about 97 cents for a liter. So there's no comparison in cost. It does add cost, but you're going to get a better transplant at the end of the day. There are default settings, but of course, when we're using, and we're going to take a little bathroom break for the patient here. That'll give us some time to catch up with counting. We're right at 5. So just to speak to the question that was posed about 2 or 3 questions ago, is do we stop? We do stop to have breaks, obviously. We're going to take a small bathroom break for the patient, but we don't stop and start implanting those grafts. We hold off on implantation. As far as setup, there are default settings that we do have that come to the robot. We can change them, and we can save those default settings for our patients. We can save them just for the specific patient of the day, or we can save the default settings for the next day. So we don't have to come in and recalibrate everything from a 24-step process like we do once every 6 months. There's a streamlined version of getting set up in the morning. And that takes a few minutes. It's basically booting the system, making sure that you are inserting your needle for dissection for that day, basically having it run a few systems checks, and you're ready to go. It's basically at that point pointing and clicking on certain buttons on a user interface. There's no entry. Yeah. Sure. I just had robot number 5 in the world, was the 5th one in the world to be delivered. It was the first in Texas. They just finished the 6-month P&M on it. So, I have them come out. Scheduled maintenance is about every 6 months, but there are upgrades to the software. There are little improvements that are made here and there, and they will come out from time to time to upgrade things, or they may retrofit something for a betterment, and that's all covered in your maintenance agreement that you could talk to about with your sales reps. Those are something that I think when we do see the service guys, they're usually here and out without us noticing them. They're not really around very often, or they come during off hours, so they're not really in our way, which is great. Well, thank you. Thank you.